So my name is John Ross. Had to find another computer screen because my laptop was a little wonky and I lost my internet connection for a bit. But I'm back and I'm going to talk about C. diff. So my background, I used to be, and still am, boarded in ID. So I'm a fellow of the ID Society of America, in addition to being a hospitalist here at the Brigham and assistant professor at Harvard Med School and one of the editors of Principles and Practice of Hospital Medicine. And I'm going to be talking about C. diff. I have no disclosures. So as you're all aware, the number one risk factor for C. difficile is antibiotics, and more antibiotics. But there are a number of other risk factors that are of some clinical importance for C. diff. One of the big ones is proton pump inhibitors. And I still think that there's a bit of a legacy feeling that hospitalized patients should be on a proton pump inhibitor for gut prophylaxis. This really isn't the case outside of the critical illness setting. And the gastric acid barrier is actually a major anti-infective barrier, and it being on a proton pump inhibitor allows people to become colonized with C. difficile in the hospital setting where there happens to be a lot of C. difficile around. Inflammatory bowel disease is another important one. So if you have any patient who's admitted to the hospital with what appears to be a flare of inflammatory bowel disease, that patient should be worked up and C. difficile excluded in that context. Any kind of gut manipulation, surgery, placement of an NG tube and tube feeds increases the risk of C. diff. The patient with the geriatric dwindles is at higher risk of C. difficile, so advanced age, poor functional status, many comorbid conditions. Patients who are malnourished are at higher risk of C. difficile, in particular because they're not able to make antibodies to toxin. Interestingly, there's a recent study that showed that if you were a hospital patient and you slept in the same bed as somebody who received antibiotics, this was actually a risk factor for C. diff. And probably what's going on there is that the previous patient who received the antibiotics became colonized with C. diff and was excreting C. difficile into the hospital environment without yet having C. difficile colitis, or in many cases, never actually getting C. difficile. All right, question. Which of the following antibiotics used in the treatment of COPD flares is least likely to cause C. difficile colitis? Amoxicillin clavulanic acid, azithromycin, doxycycline, and levofloxacin. So which is least likely? All right, so I'm seeing a lot of responses for doxycycline. I'm seeing a little bit of love for azithromycin as well. So the correct answer is actually doxycycline. So in terms of antibiotic exposure and C. difficile risk, so one thing that you should know is that clindamycin is off the charts in terms of C. difficile risk. So clindamycin has a very high hazard ratio for giving patients C. diff, in excess of 20. So if you want to give your patients C. difficile, give them clindamycin. So this is a drug that we really don't use a lot anymore because there's many agents that are able to accomplish the same thing and don't carry anywhere nearly as high the risk of C. difficile. So fluoroquinolones, back in the dark ages when I was an ID fellow, it was said that fluoroquinolones was a super low risk of C. difficile. So it turns out that in the many centuries, eons since I was an ID fellow, that C. difficile has developed resistance to fluoroquinolones. In fact, almost all C. difficile is fluoroquinolone resistant. So fluoroquinolones are another very good drug for giving people C. diff. The other agents, so third and fourth generation cephalosporins, also quite high risk agents. First and second generation cephalosporins, less so. Beta-lactam, beta-lactamase inhibitors are pretty good. Macrolides are a low risk agent, but not as low risk as trimethoprim sulfa. And actually, doxycycline actually seems to be protective, interestingly, for C. difficile. So this is a drug that if you're looking to cover atypicals in the hospital setting, is a great agent to use to cover atypicals and also to have a very low C. diff risk for your patient. This is a study that was done in the VA system and published this year. It was a retrospective study of 150,000 patients with community-acquired pneumonia. And it was shown that ceftriaxone and doxycycline used in combination had a 17% less risk of C. difficile compared to ceftriaxone and azithromycin, interestingly enough. In the subset of patients who had previously had C. difficile, if they received doxycycline, they were at 45% less likely to get C. diff again. So, good drug to use for your patients to protect them against C. difficile. Another risk factor of note is household exposure. So sometimes you'll have a patient with C. difficile and the family members will ask you at discharge, well, it's like, do I need to take precautions? What do I need to do? Should my husband be sleeping in a separate room? And we used to say, probably not. And actually, so there's some data that household exposure is a risk factor for C. difficile. So about 5% of patients who get C. diff have been a household contact of somebody with a C. diff diagnosis in the last 2 months. And the incidence rate ratio of having a household contact is 22, so very high. So if you are sending somebody home with C. diff, particularly if they have a spouse or family member who's older, possibly sicker, more chronic conditions, it's a good idea for that patient with C. diff to, first of all, wash hands, disinfect the bathroom, ideally use a separate bathroom than the one that the partner and other family members are using, and also to be careful in the kitchen as well. All right, there's always, when I give this talk, a lot of interest about probiotics. And spoiler alert, I'm fairly negative about these, as are the official societies. So neither the American College of Gastroenterology nor the ID Society of America currently recommends probiotics for C. difficile prevention. So I'll review some of the data for this in more detail. So if you look at the most recent Cochrane meta-analysis of this, it showed a modest benefit of probiotics in C. difficile prevention. The data, the authors commented that is sketchy. So a lot of small, poorly controlled studies with missing data, high risk of bias. And in fact, the positive result relied almost exclusively on 5 studies with C. difficile rates of more than 15%. I don't know if any of you work in hospitals where 15% of your patients are getting C. diff. That's an extraordinarily high rate of C. difficile. It's almost like you're, like those misters in the supermarket, in the produce section, like you'd have to have those like spreading C. diff in the air to give that many patients C. diff. So it turns out that the major predictor, so this is a somewhat cynical study that was published in 2014, looking at funding of studies and the likelihood of showing a benefit of probiotics, and essentially showed that all of the publicly funded studies were negative studies, and most of the industry-funded studies were positive for showing a benefit of probiotics. So if you tossed out the industry-funded studies, they were all negative. The largest single study of probiotics that's been done in terms of a trial, this is the PLACID study that was published some years ago in Lancet. So this is almost 3,000 patients. It's a high-quality, multi-center, double-blinded, randomized controlled trial, 7 times larger than the next RCT that had been done. So this is looking at 2 probiotics, Lactobacillus and Bifidobacterium, versus placebo for 21 days. And bottom line, no benefit in terms of preventing either diarrhea or C. difficile colitis. So large negative randomized controlled trial. This is a kind of a, not a randomized controlled trial, but a pretty good study that was done looking at a computer prompt. So this was a hospital system, I believe, in Maryland that basically, 4 Maryland hospitals. And they looked at 2 time periods. They looked at, kind of baseline, and then they put a prompt in their electronic health record, EPIC, saying that such and such a patient is at high risk of C. difficile because they have such and such risk factors. We think you should try ordering a probiotic for this patient. So they had a lot of data. They did propensity match scoring of the data. It was a negative study. So, over 30,000 patients, no benefit in this real world study. So, probiotics intuitively makes a lot of sense to us. This is something that should work. Why doesn't it work? And so the reason is probably that our gut flora is very complicated, and that the probiotics that we use are a paltry imitation of our complex normal gut flora, amateurish production. And so it turns out that, if you look at, we're going to talk more about fecal transplantation later. If you look at the bacterial species that are associated with successful fecal transplantation, they're all bacteria that you and I have never heard of. So these are, it's not lactobacillus, it's not Saccharomyces, it's weirdo, anonymous, happy little anaerobes like Akkermansia and Allostepes and Phocaelicola, Phascolarctum bacterium. So these are all non-pathogenic anaerobic gut flora that mind their own business, keep us healthy. So this is really the kind of thing that you need. The probiotics that we use are just not that important in terms of their importance in the normal gut microbiota. All right, so I think you're all familiar with the clinical features of C. difficile colitis. Typical onset is 5 to 10 days after antibiotics, but it's highly variable. Can be very early, within 24, 48 hours in people that have previously had C. diff particularly. Usually watery diarrhea, bloody in a minority of patients, and these are typically the sicker patients that have more colitis and higher risk of megacolon. Patients may or may not have fever, crampy abdominal pain, tenderness. Geriatric patients with C. diff may have failure to thrive or delirium. The older term for C. difficile colitis, back before we knew that C. difficile caused this, was pseudomembranous colitis. So pseudomembranes are these grayish, nasty, necrotic film of dead cells that's present in the colon in some patients with C. diff. So it's only present about half the time. So it's not, it's not a sensitive marker, but it's a fairly specific marker for C. difficile. There is an entity of C. difficile ileitis. So, do you have to have a colon to get C. difficile? So it turns out that a few patients that have had total colectomies can get C. difficile ileitis with a similar batch of risk factors to, kind of regular C. difficile colitis. So occasionally seen, not that clinically important. So the major laboratory feature of C. difficile colitis is leukocytosis. So you probably maybe have had the experience of you're getting ready to discharge Mrs. Jones, and, she looks pretty good. Maybe I'll just get some labs on the day of discharge. She's getting better from her community-acquired pneumonia, and you get the labs back and her white count's 30. And what the heck's going on? And it's like, well, I guess I can't really send her home. And then in the afternoon, she starts having profuse watery diarrhea. So leukocytosis can be a sign of occult or very early C. difficile colitis. So often they get this big-time leukocytosis before the development of symptomatology. And it's actually prognosis. So people with white counts of 30 or 40 are sicker, more likely to have multiple relapses. So it's a poor prognostic marker. People that have fulminant colitis may have lactic acidosis. Procalcitonin, this is one of those conditions that procalcitonin, maybe like all conditions, but like many conditions, unfortunately, procalcitonin is not that sensitive or useful. So diagnostic testing. So the first thing is for C. difficile, do not check a C. diff if the patient's having formed stools. So the stool should be diarrheal. It should not be formed. It must assume the shape of the container. If it's a fully formed poo, like in a poo emoji, do not send a C. difficile testing. If patients are asymptomatic or if they're on aggressive laxative regimens, do not test. The old gold standard for this was the cytotoxicity assay. So this was used as cell fibroblast monolayer, and it took 48 hours, and you'd have to look at that under the microscope and look for cytopathic changes. So excellent, very sensitive test, but also expensive, labor intensive, and has a long turnaround time. So that has been supplanted with 3 second-generation tests. So the workhorse that's used in a lot of places is the toxin enzyme immunoassay. So this is a dirt cheap test, relatively. It's maybe not that sensitive, depending on whose data you look at. So you have to be a little careful, I think, about ruling out C. difficile when there's a high pretest probability with a single toxin enzyme immunoassay, because it may not be that sensitive. So this should not be the only test that you use. You should do other testing. So the other test that you do as a first-line test is an enzyme immunoassay for glutamate dehydrogenase, which is a surface protein on C. difficile. So very sensitive, but not that specific. In particular, it doesn't distinguish between colonization with C. difficile and a pathogenic infection, and it doesn't distinguish between toxigenic strains and non-toxigenic strains. And the test that we use is a tiebreaker. In a lot of institutions, you will use a PCR for toxin B. So this is the cytotoxin. It's kind of the modern version of the cell cytotoxicity assay. Rapid test, more expensive, but very sensitive. It may not be 100% specific, so you occasionally will see somebody who isn't sick, and the PCR test was sent off for some reason, and so you still need to interpret it in light of the clinical picture. So this is a typical testing algorithm. So we'd send off the glutamate dehydrogenase and the toxin. If they're both positive, you're all set. Patient has C. difficile colitis. If they're both negative, you're all set. Patient doesn't have C. difficile infection. If one of those is positive, the best way to proceed probably is to use the PCR for toxin B as a tiebreaker. If it's positive, C. diff. If it's negative, not C. diff. So we used to have in C. diff, we used to distinguish between mild, moderate, and severe, and have this criteria, and it turns out that that isn't really helpful in terms of treatment. So now we just talk about the treatment of fulminant and non-fulminant C. difficile. So anybody with non-fulminant C. diff, if they're not deathly ill with C. diff, we either treat them with fidaxomicin. IDSA recommends that, and the American College of Gastro says you can use either vanco or fidaxomicin. IDSA says oral vanco is okay, maybe not the best. So drill into this a little bit more here. So fidaxomicin is a narrow-spectrum macrocyclic antibiotic. So in the studies that have been done, when you give a conventional, regimen of fidaxomicin versus vanco, they're essentially equivalent for, kind of short-term cure. The patients treated with fidaxomicin tend to do a little better, however, in terms of relapse. So relapse is a little more common with vanco, and I'll maybe get into some of the recent data that we have for that. It's occasionally patients will have issues with gout and neutropenia and GI bleeding, but generally this is uncommon and not a consistent association. The major reason why we're not using more fidaxomicin is it's very expensive and typically not covered by insurances. So it's about close to $3,000 for a 10-day course. Fidaxomicin, so it turns out that one thing you can do to make fidaxomicin a little more effective is to give it in this kind of extended pulse or kind of tapered regimen, where you give it twice daily for 5 days, then every other day for days 7 to 25 versus conventional dosing of vanco. So the cure rate is higher with this, 70% versus 59%. It's not clear whether that's a function of the drug or the taper or possibly both. Study that just came out this year. So C. difficile is an anaerobe, and it's not something we routinely do antibiotic sensitivity testing for. So only special labs that can work with anaerobes and have some money to throw around do this. So this is a study out of Houston this year where they actually calculated sensitivities to vancomycin for 300 isolates. So this was not something that your hospital, if you ask your hospital microlab to do this, they're going to laugh at you. So don't ask them to do that. But in this specialty lab that was set up to do this, there were 34% of isolates showed reduced susceptibility to vancomycin. So interesting. And so the patients that had reduced vancosensitivity had pretty good outcomes, but not as good as the group that had full sensitivity to vanco. So I think the reasons for that is when you take this drug orally, so vancomycin, as you know, is not absorbed, it stays in the gut. So even if there is some reduction in susceptibility, you're still achieving high concentrations in the gut locally. And that probably is okay for most patients, but maybe not all of them. But the patients that had reduced vancosensitivity did have lower rates of cure at 14 days, so 89 versus 96%. That was a significant value. And lower rates of sustained remission at 30 days as well, so 76% versus 86%. All right, so that was non-fulminant C. diff. We're going to talk about fulminant C. diff. So fulminant C. diff, patient is very ill. They're hypotensive, they're shocky, or they have ileus, or they have toxic megacolon. And basically these patients, you throw everything at them, throw the kitchen sink at them. So you're giving high dose, so not 125, you're giving 500 vanco 4 times a day through an NG tube if you need to. You're giving IV metronidazole, which may or may not be doing anything. You may consider doing rectal vancomycin. And the American College of Gastro says that this is a patient population which you should probably have a low threshold to do fecal microbiota transplantation in. So just to follow up on the metronidazole thing, so there's a fair amount of studies that have been done, all retrospective, that have shown that IV metronidazole, at least retrospectively, doesn't seem to have a lot of benefits. So it's something we use. It doesn't achieve very high concentrations in the gut, and the only nice thing about IV metronidazole, if the patient has an ileus, you're sort of getting something in there, but you're maybe not getting that much. So we still give IV metronidazole, but it's a pretty mid drug for C. difficile, as the kids say. One of the things, so if you have somebody with fulminant C. difficile, you should consult general surgery for these patients. So the general surgeons don't need to see your run-of-the-mill patients with C. diff, but they definitely 100% should see the patients with fulminant C. difficile. One of the things that can be done short of colectomy is doing a loop ileostomy. And what that does is it enables you to get high-dose vanco into the gut. And this isn't something that there have been randomized controlled trials, but there are retrospective trials that show that it does reduce the risk in selected populations. It does appear to reduce the risk of progression to colectomy. All right, I'm going to talk about relapse. So probably a lot of you had the frustrating experience of treating patients with multiple relapses of C. difficile colitis, and it's like going, to the carnival and playing whack-a-mole. So why is it that why is this such an issue with C. difficile? So it turns out that C. difficile, if it's kind of getting stressed out, if it senses that the environment is hostile, maybe there's not as many nutrients, maybe there's some antibiotics around. But when C. difficile gets stressed out, it's one of those bacteria that can form a spore. So it's going to go, I don't like this, and it's going to sporulate, it's going to encase itself in this thick wall, and it's going to go into a low metabolic vegetative state. And essentially what that does is it makes it impervious to antibiotics. So you can throw any amount of antibiotics at C. difficile spores and you will not kill them. They are impregnable when they're in the spore form. You cannot get rid of them. This is also why having a lot of C. difficile in your hospital is bad, because the spores linger in the environment. You can kill them with disinfectants, but it's difficult to eradicate them. They're on the toilet, they're on the call button, they're on the bed rails, they're everywhere. So let's talk about the approach to the patient with relapsing C. difficile. So what is the single most effective therapy to prevent C. difficile relapse? Bezlotoxumab, which is a monoclonal antibody to toxin B, fecal transplantation, fidaxomicin, extended pulse regimen, or vancomycin treatment with taper. All right, I'm seeing a lot of love here for fecal transplantation, so excellent. So let's talk about C. difficile relapse. So there's a number of professional societies that have kind of gotten involved and opined on this. So the current IDSA recommendations for a first recurrence, fidaxomicin, either the standard or the pulse dose regimen with bezlotoxumab, which I'll talk about in a minute, or you can use a vancotaper and bezlotoxumab. American College of Gastro, either vanco or fidaxomicin. So the American Gastro Association has kind of weighed in on this, and they say, we probably should be using more fecal microbiota therapy in patients at high risk. So the IDSA for a second or subsequent recurrence says a long-term vancotaper or vancorifaximin chaser, which is rarely used, or fecal microbiota transplantation. And the gastroenterologists are unanimous that if you have a second recurrence, this is somebody that should get a fecal transplant. All right, so we'll talk about vancotaper first. So these are all kind of home remedies, but a typical taper would be something like 2 weeks of standard dose of vanco, so 125 milligrams 4 times a day for a couple of weeks, then twice a day for a week, then daily for a week, and then vanco every 2 or 3 days for 2 to 8 weeks, something like that. So kind of a long taper of about 3 months. So bezlotoxumab, this is a drug that's in the IDSA guidelines but rarely used. So it does seem to reduce the recurrence rate in the studies that have been done. So it's the recurrence rate with bezlotoxumab is about 70% versus 27% with usual care. It does not reduce all-cause mortality. It does seem to have this unusual and not well explained side effect of making CHF worse in patients with CHF. And it's quite expensive, so about $4,000. So the IDSA guidelines recommend it. Notably, there were a number of those authors who were somewhat conflicted. The gastroenterologists are not so big on this drug. And another issue that comes up with vancomycin, as long as we're on the subject of oral vancomycin, is secondary prophylaxis to prevent relapse. So if you have somebody, Mr. Smith had cholangitis and he had C. difficile, and that was a year ago, and now he's got a pneumonia, and what do you do with the C. diff issue? Should you prophylax them? So it turns out that we do have data from randomized controlled trials looking at this issue of secondary prophylaxis in patients who have previously had C. diff. And it turns out that there is a benefit to giving them prophylactic vanco. So in this study, they gave vanco 125 milligrams once a day while on antibiotics and for 5 days after. No relapses in the patients who were prophylaxed, and 12% relapsed in the patients that were on placebo. So that is recommended. All right, now we're moving on to stool transplantation. Or somewhat more grandiosely, fecal microbiota therapy. So, we sort of think about this condition, we tend to think about C. difficile colitis as an infection due to C. difficile, but we really think about it a little ass backwards, so to say, because it's really a deficiency of normal gut flora. And the definitive treatment for this is restoring the normal gut flora. So the data shows that this is the most effective treatment for C. difficile. You could even call it the Brown standard. So the benefits of fecal microbiota therapy: colonization resistance. So, if you have your Akkermansia and your other happy little anonymous anaerobes there, it denies the bad guys a place to be thriving. Normal gut flora actually helps produce compounds that kill off C. diff spores. So this is an important thing. So a number of bacteria in normal gut flora metabolize bile acids into a form that kills off C. difficile spores. So these transformed bile acids are cidal to C. diff spores, so hugely important. Bacteria make antibiotics that kill off other bacteria. They modulate innate immunity. So the cure rates are amazingly high in patients that have had multiple relapses. So patients with multiple relapses of C. diff, you achieve 80 to 90% cure versus 20 to 30% cure with conventional regimens. Another benefit is that you're less likely to have antibiotic-resistant gut flora, and as a result, less likely to get antibiotic-resistant infections. All right, so the mechanics of fecal microbiota transplantation. So this is a little convoluted, and it's one reason why, so there are substantial inertia barriers to getting fecal transplantation. You need to find a willing donor, or get stool commercially from a stool bank. So you need stool. It's got to be screened for HIV, viral hepatitis, pathogenic stool organisms, multi-drug resistant organisms. So there was a fatality a few years ago at one of our sister hospitals in a patient who got an experimental stool transplant for a non-C. diff condition and wound up getting sepsis with a multi-drug resistant organism. Contemporary stool samples need to be screened for COVID, and you need a waiting period to make sure the patient remains negative for COVID, and proceed with the transplant if they're negative for 14 days. So the stool sample needs to be homogenized with preservative-free, so do not use saline with preservatives in it. It'll kill off the bacteria. Preservative-free, non-bacteriostatic saline in a patient-provided blender until you've achieved a chocolate malted milkshake consistency. All right, so prior to the transfusion, you need to taper down the vancomycin. The stool has to be strained through gauze to filter out particulate matter. You're looking to achieve a target volume of stool of 250 to 700 cc's. Typically, the patients will get a bowel prep, and then colonoscopy. What the endoscopist is trying to do is to get the fecal transplant all the way up the colon into the right colon and terminal ileum. After the procedure, the patient lays on the right side. You may want to give them antimotility drugs such as loperamide to help them retain the stool so they don't immediately expel it. So here's some more information on what I alluded to earlier about how stool transplants reduce the risk of infection with multi-drug resistant bacteria. So one of the things that often goes along is part of this gamish of things that patients with, so the patient older, frail, malnourished, recurrent C. difficile, also multi-drug resistant infections. There's a particular profile of this patient that you see. So these patients often tend to have recurrent UTIs and other infections. And in patients that receive fecal microbiota therapy, it reduces the risk of UTI and it reduces the risk of MDR UTI. So these patients were converted from frequent multi-drug resistant infections to much less common antibiotic sensitive infections. In a meta-analysis of 21 studies, FMT was associated with a 38 to 88% eradication rate of multi-drug resistant bacteria. and was also helpful in the setting of renal transplantation in reducing carriage of MDRO bacteria. All right, I'm going to shift gears a little bit. So I'm going to talk about a couple of newer products that have been introduced, this oral microbiome therapy or so-called microbial cocktails. I would think of these as sort of fecal transplantation light, sort of the PBR of fecal transplantation. So these are processed fecal products made. So the background to this is that pharmaceutical companies decided that, if there's a way to monetize feces, we're going to do it. So that's the background. But anyway, so these products are processed feces in single donor lots that are trackable. Donor blood and stool is screened for infectious agents as per, the prior protocols: HIV, viral hepatitis, GI pathogens, resistant bacteria. And these are products that are approved to give to patients at the conclusion of primary therapy with vanco or fidaxomicin to prevent relapse in patients at high risk. So these are well tolerated in small trials with only minor nuisance side effects of abdominal pain, nausea, and transient diarrhea. So these two products are live JSLM or Rebyota. So this is a product of filtered stool suspended in saline and polyethylene glycol and frozen. The other product is live BRPK or Voust, which is suspended in alcohol. So that kills off everything except gram-positive spores. So this is, so it's a narrower spectrum of bacteria than what you would get in a full-fledged fecal transplant. And so it's suspended in ethanol and then filtered to remove solids and also to get the ethanol out. All right, so the data for live BRPK. So in a phase 3 study of 182 adults with 3 or more episodes of C. difficile, randomized 1-to-1, it reduced the recurrence rate at 8 weeks from 40% in the placebo group to 12%. And similar efficacy across subgroups. So that sounds great. Why don't we do that? And so the major barrier to this product is the astronomical cost, given that the active ingredient is feces. So it's retails for $17,500. So extraordinarily expensive. So dosing regimen. You give antibiotics, you take a laxative at the end to clear out the gut, and then you give 4 capsules daily for 3 days. The other product, Rebyota, is maybe not quite as effective, probably based on the numbers here. It's given as a single dose enema 1 to 3 days after antibiotics for C. diff. No bowel prep is necessary. The success rate at 8 weeks, meaning no relapse, is 71% versus 58% for placebo. This is somewhat more affordable at $9,000. So still a very high burden of cost and low likelihood of insurance coverage. All right, take-home messages. So in terms of treatment, so first-line therapy is either fidaxomicin or vanco. Depending on the patient's resources and insurance coverage. We may be using more fidaxomicin in the future if this issue of vanco resistance increases. Fulminant C. difficile colitis, you hit them with everything. So high-dose oral or NG tube vanco, 500 milligrams 4 times daily. Throw in some IV metronidazole just for good luck. And consider fecal microbiota transplant and get your friendly neighborhood general surgeon to see the patient in case they need either a loop ileostomy or a total colectomy. So first relapse, sort of all over the place depending on who you look at, but you're probably either going to give a vanco taper or fidaxomicin. If the patient has coverage, you may think about bezutoximab for this patient. And in patients with 2 or more relapses, definitely fecal bacteria therapy would be indicated. There's also these microbial cocktails, these sort of light fecal transplant light products, which are probably not going to. So there's a convenience factor with these products, but they still have tremendous insurance and reimbursement and cost problems that will make them unlikely to be used on a large scale in the near future. And the other important consideration, if your patient has had C. diff in the past and they need antibiotics, give them Vanco 125 once daily while they're on antibiotics, and then for 5 days afterward. Thank you very much for your attention, and I think my colleague, Dr. Schaefer, is here with some questions.
Thank you so much, Dr. Ross, for that really sort of outstanding and comprehensive talk. Much appreciated. So one question a lot of the questions actually have to do, fall within the sphere of infection control. So for one, when is a good time to discontinue C. diff isolation to facilitate discharge from the hospital?
Yeah, so this is a great question, and there's no guidance or no consensus. So we tend to have in our hospital a fairly, I would say, maybe authoritarian infection control regime, and their answer would be never. So if you so C. difficile is one of those conditions, I think we probably go overboard on a lot of infection control precautions for patients. And C. difficile is one of those things where I think in the hospital setting, you can't go overboard because it's very easy for people to spread this around. So like the person who's bringing around, so in terms of spreading this from room to room, like if the person bringing in the breakfast tray isn't gowning up and they happen to touch a bunch of stuff in the room on the way in and out, they can spread it to the next room. So it's a great question. I wish I had a good answer for you. That it would really come down to CDC. This is one of those areas where CDC offers no guidance. And they're sort of loath to, and there's no clinical consensus. So it really comes down to your local infection control culture. Some hospitals will be perhaps willing to take patients off precautions if they're negative a couple of times. So, here at the Brigham, it's you're on precautions until discharge. They will not take people off precautions.
Got it. Thank you very much. And sort of the next most popular question, also within the realm of infection control. You talked about how when a patient is at home, their close contacts at home should potentially use another bathroom and wash their hands. Is there any data? Are you able to give any advice on the duration of this sort of domestic infection control? At what point can they after their C. diff bout, can they reduce or stop these home precautions?
Yeah, so I don't think there's any firm guidance. I think it would be reasonable to do this for 2 weeks, certainly, and possibly 4 weeks, depending on how the patients are doing. It's basically, we know when people recover from C. diff, it takes a while for them to repopulate their gut flora, and there is that risk of recurrence is always a huge issue in some patients. So I would say a few weeks. Ballpark, probably 4 weeks.
Got it. Thank you. And do you have any thoughts about sort of the optimum approach to nutritional support in these patients? Oftentimes, given all the GI symptoms, they may be having anorexia, may not be taking a lot in. Do you think it's advisable to, let's say, be more aggressive in terms of when we initiate NG tubes, so we can do sort of enteral feeding that way? Or what's your thought about the approach to nutrition in these patients?
Yeah, so I think they certainly benefit from nutrition. It's an issue, certainly, and it was particularly an issue, kind of not that long ago. These patients were getting oral metronidazole. We don't use that anymore because it's been shown to be less effective. But if you go back 10 or 15 years, these patients were all getting metronidazole, and they would get even worse anorexia. I would say if you're on the fence about whether somebody needs, NG tube feeding, knowing that they have C. diff, I think should be something that pushes you to, be more aggressive. If your nutritionist is kind of like, maybe, probably, then you'll say yes.
Okay.
It's a very non-wishy-washy answer for me.
Thank you very much. No, I appreciate you sort of summarizing the best evidence that we have. A lot of patients are sort of, maybe interested or enthusiastic about probiotics. So let's say the patient comes to you. I mean, doc, is there any harm? I've heard it's good. Do you sort of actively discourage them, even in the absence of evidence? Because, a lot of patients really sort of are interested in them. So the patient says, like, I'd really like to take probiotics. I read on the internet it can be helpful. Are you going to actively discourage them, or sort of what would be your response in that setting?
Yeah, so it's kind of funny. So I kind of set the talk up to be very dogmatic about probiotics, but people still love them. No, it's a good question. I mean, it's definitely, this is something that's out there in the popular culture, that probiotics are good for you. And, there's a very deep-rooted thing with yogurt's good for you that goes back 100 years in medical culture, because it has these good bacteria in it. So it's a very deep-rooted thing, even if the evidence isn't there. I would say generally that it's harmless. It's just, it's, a couple things. One is the evidence isn't there that it works. Number two, if the patient's on antibiotics, they're just going to kill off the bacteria in the probiotics. If patient families feel better about it, it's okay. There's probably no downside of it. The one thing I would say is in a prior iteration of this talk, I had a slide about Saccharomyces boulardii, which there's a little better evidence for than some of the other things. So if you really feel like you want to give a probiotic, or the family really wants to give a probiotic, there's a little better evidence for Saccharomyces boulardii than some of the other things.
Okay, thank you. And as a last question, someone asked about optimal dosing of oral vancomycin. A lot of the recommendations are, I think, 125 POQ6, but is there any role for a higher dose of oral vancomycin, let's say 250 POQ6?
Yeah, I would say in general that the evidence for that there's not great evidence for the higher dose. We used to use a higher dose more often, and then the consensus guidelines kind of centered around 125. There is a downside too, by the way, of using oral vancomycin in terms of infection control, that if you're using a lot of oral vancomycin, you tend to wind up with more problem in your hospital with vancomycin-resistant enterococci. You tend to select for it more, and I think that's from an infection control perspective. There's some leeriness about using the higher doses of vanco for that reason, that you probably will wind up with more VRE. I would say that, for the time being, that there's no evidence. If this reduced susceptibility to vanco becomes more of an issue, we may be forced to use higher doses, unless fidaxomicin becomes a lot cheaper. So I say it's a to be, kind of on the watch, list of things, but it's not quite there now.
Okay. Well, thank you very much, Dr. Ross, for putting up with my barrage of questions. And we are going to have a break, and we'll be coming back at 5:05 with Dr. Andrew Hayden, talking about common ID consults. I think that's going to be a great, extremely relevant talk. So we look forward to seeing you back here at 5:05. Thank you very much.